I'm Rachel Oxman. I'm an adult endocrinologist at UCLA. So I'll be speaking to you today about gestational and pregestational diabetes and cystic fibrosis pregnancy. So I think it's first important to acknowledge that pregnancy in CF is no longer the rarity it once was. So we know that there have been important survival improvements over time, and that as of 2019, the median predicted survival age was 48.4 years, and very importantly, this was not including the effect of Trikafta, which we obviously expect to be positively dramatic. As a result of improved survival, we're also seeing that over 50% of individuals living with CF are now adults, and with that have come very important demographic changes, such that now nearly, the number of individuals living with CF who are living with a partner have tripled since 1999 compared to 2019 statistics, and that the number of pregnancies have more than doubled in that same period. So I think it's important to, as providers and for women living with CF to know what to expect once someone is going through pregnancy with CF. And so there are, first and foremost, many women living with CF will be able to safely pursue pregnancy. But once pregnant, there are a number of complications to be aware of, including increased incidence of CF exacerbations, increased constipation or DO flares, difficulty with weight gain, and increased incidence of gestational diabetes, which we will get into detail shortly. We want to have preconception optimization, which includes obtaining a BMI of 22 or higher, and ensuring that any pre-existing diabetes is optimized, and I would like to emphasize diagnosed, because you cannot optimize what you don't know is there. And that most CF pregnancies will result in live births, 83.1%, and this was a pretty large, I would say, composite study that included 523 pregnancies. And so we as providers certainly should expect to see more CF pregnancies and be prepared to help women navigate that. Great. So diabetes in CF pregnancy takes two primary forms. We have gestational diabetes as well as pregestational cystic fibrosis related diabetes. And we know that 35 to 50% of CF pregnancies will be affected by diabetes. And that's from our more recent retrospective cohort studies. And so the question is, why is prevalence so high? Well, first of all, we know that CFRD is more prevalent with improved survival, and that 40 to 50% of adults will be affected by cystic fibrosis-related diabetes. But additionally, gestational diabetes is more prevalent in women with CF than the general population. And we actually know why, which is nice. Okay, so this was a study by Hardin, which I'll get into in a moment. But first, I just want to emphasize that during pregnancy, any woman needs to increase their insulin production 2 to 3 times pre-pregnancy levels to meet the demand of pregnancy. And when they are unable to do that, gestational diabetes develops. Mothers with CF actually have lower insulin secretion and higher insulin resistance, or another way to term that is lower insulin sensitivity, compared to pregnant mothers without CF. And so I have manipulated the C-peptide chart a little bit just to make it easier to read. But what you'll see is that CF mothers in a second trimester had a C-peptide level of 1.4, and that really did not change in the third trimester with a C-peptide level of 1.5, whereas mothers without CF had a second trimester C-peptide of 1.7 and a third trimester C-peptide of 2.6. So they were really able to increase their insulin production. In the other image, you see that CF mothers are represented by the black bars, and their insulin sensitivity is significantly lower than both mothers without CF and cystic fibrosis women who are not pregnant. And so you really see that insulin resistance rising for them. So what do we know about fetal complications related to diabetes and pregnancy? We know quite a bit from the general population, so I'll just run through this quickly. So in gestational diabetes, we know that it is associated with increased birth weight or macrosomia. We have increased risk of fetal trauma like shoulder dystocia. There can be small for gestational age, neonatal hypoglycemia, hyperbilirubinemia, respiratory compromise, and NICU admission, as well as, unfortunately, increased risk for fetal demise. Pregestational diabetes is a little different because it affects the first trimester of pregnancy, unlike gestational diabetes, which typically evolves in the second trimester. And that is important because in first trimester is when organogenesis occurs. And so pregestational diabetes will carry all the same risks of gestational diabetes, plus there's a risk for congenital malformation. And we see that specifically affect the neural tube, cardiac system, GI, urinary systems, and there is a much increased risk for caudal regression, although still a relative rarity. There's increased risk of perinatal mortality and neonatal mortality, and I think it's important for all of these outcomes, congenital malformations and the mortalities, that risk is really associated with the A1C in first trimester, and that the risk actually begins at a very low A1C of 5.6% or higher. Now it is proportional, so the higher the A1C, the greater the risk for these fetal complications, but the risk is there even in the what we would consider prediabetes levels under normal circumstances. So what do we know about fetal complications of diabetes in CF pregnancy? And we do know a couple things. There are multiple studies to suggest that there's a higher risk of preterm delivery and lower birth weight in CF pregnancy with diabetes compared to CF pregnancy without diabetes. Now, this is always tricky because we're not always able to reach statistical significance because of small sample sizes or study design. And there's also important confounders, which is that diabetes in CF pregnancy also tends to present in the women with lower FEV1. So what is really causing what? Other fetal complications that I mentioned on the prior slide, like hypoglycemia or hyperbilirubinemia, respiratory distress, et cetera, have not been specifically studied or documented. So this is the, I feel, is the highest quality study we have about fetal complications in CF pregnancy. And this was a study, a retrospective cohort of 54 pregnancies in 36 women. And it was among women who were homozygous and heterozygous for 508 deletion. And within their study, they included a comparison of CF pregnancy with and without diabetes and the complications. And what you can see here by the green stars is that women, pregnancies affected by diabetes had greater rates of premature rupture of membranes. They had younger gestational age at delivery, higher rates of preterm delivery, and lower birth weight. So what about treatment? How does treatment influence fetal outcomes? The answer is yes, it absolutely will affect outcomes, but we don't have CF-specific information. So there is not yet a study that I'm aware of that looks at how diabetes treatment might affect fetal outcomes, but we do have robust data from the general population that's really extensive and compelling. I've summarized 3 of some of the bigger landmark studies here, and what you'll see is that the top 2 studies, the Australian study and Landon study, looked at gestational diabetes and treatment. Treatment would include dietary advice, glucose monitoring, and initiation of insulin as indicated. And what you can see on the outcome side is that both serious and less serious fetal complications were significantly less frequent in the treatment group compared to the controls. In the bottom study, which is the Atlantic Diabetes Program, this study looked at pregestational diabetes, including both type 1 and type 2 diabetes, and they compared periods before the program implementation and afterwards, as far as rate of complications, and the program successfully increased prenatal care, folic acid supplementation, and improved A1Cs in first and second trimester. And you can see that there was a impressive improvement with malformation rates declining from 5% to 1.8%, and stillbirths reducing from 2.3 to 0.4%. Great. So what are the diabetes treatment targets in pregnancy? So first we guide treatment targets by fingerstick glucoses, and the targets are the same regardless of the type of diabetes you're talking about. So whether it's cystic fibrosis diabetes, gestational type 1 or type 2, we're looking for fastings to be less than 95, 1 hour postprandials to be less than 140, and I would emphasize that the 1 hour test is time from first bite of food, not last bite of food, and 2 hour postprandial glucose is less than 120. The A1C is ideally maintained less than 6% throughout the pregnancy to minimize fetal risks. But there is a caveat, which is that if mother is experiencing excessive hypoglycemia, you are permitted to loosen the A1C target to 7% because we're always balancing maternal health and fetal health. As far as CF-specific, just to emphasize that, glucose monitoring is recommended by finger sticks. Obviously, many of us in this room favor technologies. There is evidence that we can supplement with continuous glucose monitors, and there is the concept trial documented improvements in pregnancy outcomes when you use CGM in type 1 diabetics, and so we have data for that. When we think about CF-specific considerations, obviously these pregnancies are different than pregnancies in the general population. And it's important to recognize, or at least in my personal experience, and I imagine probably some of the experience in this room, that these glucose targets can be exceptionally difficult to reach in cystic fibrosis-related diabetes or those living with CF, especially the postprandial targets without later hypoglycemia, and I found that to be a challenge. And that, we're also dealing with variable insulin resistance and response, just like we deal with when individuals are not pregnant, right? So these women are experiencing CF exacerbations even more so than usual. They might be on steroid regimens. They might have exacerbations of their DOS. And so it can be a really challenging thing that requires a lot of good communication and education and attention. As far as management choices, insulin is first-line therapy in all types of diabetes and pregnancy, and that is because insulin is highly effective and it does not cross the placenta. We tend to favor category B insulins like MPH, Detamir, Levemir, and Aspart. Regular insulin is also a category B insulin, but I can't imagine you'd actually keep your postprandials at target with that insulin. And so I don't personally use it very much. You may give insulin through subcutaneous injections or insulin pumps. We have to keep in mind that nutrition recommendations should be tailored for our women with CF who are pregnant because they have higher nutritional demands, and we know that they have difficulty with weight gain in pregnancy, unlike the general population. So as far as my conclusions, women living with CF are increasingly pursuing pregnancy, and that diabetes, either gestational or pregestational, is highly prevalent in CF pregnancy. Diabetes control is exceptionally important for fetal outcomes, and treatment reduces the risk of fetal complications. The most common complication of diabetes in CF pregnancy are both increased preterm delivery and low birth weight, although preterm delivery is especially well documented. Those with pregestational diabetes should definitely be optimized prior to conception to the best of your ability to minimize malformation risks. And arguably all CF women who are considering pregnancy should be warned about the possibility of diabetes in their pregnancy. And that I believe that the management of diabetes in CF pregnancy requires an intensive endocrine care. And with that, I am finished. Perfect. Thank you.